It's great to have today Patricia Davies, who's Chief Executive of Shropshire Community Health Trust. And Patricia has been working with the Purpose Coalition for well over a year now. And what I'd like, Patricia, you to be able to tell us is a little bit more about the really innovative work that you're doing in Shropshire. I know you did a fantastic job during the pandemic with very high rates of vaccinations targeting homeless people. But, following that success, you've now been doing an awful lot of work with the acute trusts and also within the community. So maybe we should start with virtual wards and explain to people who don't understand what that means, actually, Patricia.
Yes, and actually it is causing quite a lot of confusion, or has been causing a lot of confusion with members of the public that think virtual means technology. And for sure, we do use technology in the virtual ward, but in essence, a virtual ward is being cared for in your own home, or what you call home. So it's an individual whose condition, it might be a chest infection, it might be an acute condition, where we provide that treatment in people's homes through consultant oversight, with advanced care practitioners, nurses, therapists and others going into people's homes, sometimes 2 or 3, 4 times a day, in order to deliver treatments such as IV antibiotics, fluids, the kind of treatments that you would normally see within a hospital bed or a hospital setting, which through technology and advanced care can be done in people's homes. And normally the stay on a virtual ward is around the 9 to 14 days mark. So it's not dealing with people who've got persistent and enduring long-term conditions that are managed in the community. These are people who are having an acute episode whereby their condition can be managed by bringing that treatment to them in their own home, rather than them going into hospital. Or sometimes if they do need to go into hospital for that very acute episode, we can turn them around very quickly and bring them back home so that they can receive, once stable, the rest of their acute treatment in their own bed, which we know from evidence, from a rehabilitative point of view and an acute point of view, that people respond far better, particularly older adults with complex needs respond far better, don't become deconditioned because they're in a hospital bed. They're surrounded by things that are familiar to them. So this is a way of delivering high-tech hospital care, but within people's homes.
And these are people who would have otherwise gone into hospital.
Absolutely, yes. Yeah.
So in terms of bed days out of hospital, that they're mounting up, you are really making a difference, and in doing so, making a difference to the acute trust.
Yeah, I mean, to put it into context, that we've treated over 4,500 patients during the time that we've been running the virtual wards, which was a slow burn to begin with back in sort of December 2022 going into 23 year. And we've built up, so we now have 167 virtual beds, which are people's home. They're the bed, yes. the place they call home, 167 beds, and we're operating anywhere between a sort of 70% occupancy, between 70 and 80%. Ideally, we want to achieve 90% occupancy and above in those beds. But we've treated more than 4,500 patients. And in terms of the readmission rate of those patients, I can name about 5 or 6 that have gone back into hospital, but with different conditions much later on. So we're keeping people, not only treating them at home, but we're then managing their ongoing conditions and keeping them at home for longer, so they're not bouncing back in. So that's been a huge success. And in a community such as ours in Shropshire, Telford and Wrekin, which is covering 1,300 square miles with rurality. So if you live in Bishop's Castle, your nearest hospital is a 15-minute blue light journey away. That makes a big difference, both in terms of getting your treatment quickly and effectively, but also in terms of your rehabilitation and your support services. So that's been a real plus. It's released in real terms about the equivalent of 90 beds within the acute trust over that at that period of time. So the impact of those 4,500 patients in real terms has suppressed growth in terms of the activity going to the acute trust, which is still under stress in terms of ambulance waits and non-elective care, but it would have been a lot worse this winter if we didn't have the virtual ward in place.
And as you rightly say, first and foremost, this is good for the people you're caring for, because it's been well documented for decades that going into hospital isn't the best idea, particularly if you're elderly and you don't have the familiar things around you, mobility decreases, etc. But this is very dependent on the advanced care practitioners. Just tell me a little bit about them.
Yeah, so they come from a range of professions. It's mainly nursing, and these are individuals who've worked predominantly in the community and the acute. They have advanced skills in physical assessment of patients and meeting the needs of patients to be able to deliver a high range of treatments. So these are if you can remember back to your days nursing, they'd be sort of registrar level of skill in terms of being able to deliver care and treatment to patients. So advanced care practitioners can be physios, they can be nurses that have then done advanced clinical practice to be able to both assess and deliver high-tech treatments to individuals. And some of those are also teaching carers and the individuals to deliver the treatments to themselves, which we can then monitor remotely using technology. So we do use technology as a mechanism of determining how often we have to go in and deliver treatments, which has its benefits also, because as you're teaching the individual to manage their condition, they're understanding their symptoms a lot better. So that's part of the rehabilitative process.
And never to miss an opportunity for recruitment. Of course, this is a wonderful innovation for people coming into the NHS, training as a nurse, maybe on an apprenticeship, because these are sort of roles that you don't get to hear about, but enormously satisfying for as you say, predominantly nurses that are involved.
Absolutely. And it's some of the nurses aren't just nurses that come from a community background, but they come from the acute as well. They're actually joint employees. So a lot of our nurses work across into some of the advanced, the medical assessment units and A&E. So we've got a whole range of people who are rotating, using their skills in different ways, which makes for far more varied and interesting jobs and roles.
And just tell me about the families of the patients that you're looking after, because that can sometimes be a bit of tension. They sometimes want their relative in hospital because they don't understand the sort of care that can be delivered at home.
Yeah, so we've done an awful lot with our patient experience group and the patients have gone through the virtual ward to try and explain the language a little bit better, because again, when you say I'm going to admit you to a virtual ward, people kind of think that they're going to be put into some cyberspace where they've forgotten in the back of nowhere. What the hell does that mean? And I'll have lots of machines around me, but not a human being that's going to care for me. So the big worry is, well, how can my mum be looked after at home when she's this sick and unwell? And it's real people that are going into homes. Technology is a part of it. So using the patients themselves, and there's a beautiful video which is on our board website, which I'll share with you, that is made by patients around their experience of the virtual ward. And there are two patients on there, one who is a young lady in her mid-20s, because this isn't all about older, frail people. By definition, the majority of patients that we treat are in that category. But there are a lot of younger people as well. And this is a lady who has a particular condition that means she's susceptible to going into hospital on a regular basis for treatment, particularly intravenous treatments. And we've managed to put her on the virtual ward, and in doing so, she hasn't had a return to hospital. So she's a lady that often goes in every couple of months with an acute related episode to a condition. Now being kept at home, the virtual ward can go in and provide that acute treatment, which means she can start to live her life a little bit more effectively. She can start to think about, well, perhaps getting a job and working isn't that far removed from what I can do, having more of a life with her friends and a community, and a gentleman that's an older gentleman with chronic obstructive airways disease that's at the stage of his condition where he gets pneumonia and chest infections very frequently. Each time he'd been going into hospital meant that he was decompensating, and he kind of said, I'm so grateful to the virtual ward because I'm now at home, I know who I can contact, and I really thought that the last admission to hospital would mean me having to go into a home. So it's about that independence and giving people back their lives, as well as more effectively being able to provide treatments, which, in this climate is at cheaper cost too. Going into hospital is expensive. Taking up a bed in an acute trust is expensive, but the cost to the individual is so much more, and their families. So it's through those kind of patient experiences and patient videos and patients talking to other patients that we've really started to get the message out around the virtual ward, or as they like to call it, hospital at home. We're used to that terminology. It is hospital at home, which uses a blend of technology, but mostly human beings.
Which is fantastic, and the testaments of people who've been treated by you say it all, I'm sure. Patricia, now you're doing another initiative, aren't you, with the Acute Trust, which is, if you like, if there's a line between the community and the Acute Trust, this is jumping over the other side of the line.
Yes, there's many examples of acute trusts running community services, and as a district practicing district nurse and as a chief executive of a community trust, I kind of think that isn't necessarily the best model, because you tend to see things from the acute lens. But we are doing something jointly with the Acute Trust, whereby we have taken over 2 wards within the local acute trust. So 2 site trusts, so a ward on each site, running what we call subacute care, or rehabilitation and recovery units. These are for patients who, at the end of the day, our motto is home first. So if somebody has gone into hospital, can we turn them around quickly and put them on a virtual ward and get them home? Because that's the best approach to rehabilitative and acute care. If that isn't possible for whatever reason, either because the individual's home circumstances are such that it doesn't allow us to deliver that kind of clinical treatment in their environment, and there are areas sometimes where that's not possible, or because their condition, acute condition, subacute condition, is oscillating slightly, so they're going in and out of the acute phase of illness, where perhaps backup facilities are therefore necessary. We've developed 2 what I call subacute wards. So these are wards where people can transfer, which means if they're still in that grey zone of oscillating between, there are the backup services that we can call on from the Acute Trust, but primarily we're running those wards, so the wards have a focus around rehabilitation, reablement, getting people back home, and that's been running for since the 2nd of January, 52 beds. The first, I think, in the country where the community trust is occupying the space of the Acute Trust and being the primary leader of the care delivery within an acute in general medical beds. And again, that difference in the delivery of rehabilitation with a focus on getting people home, I think has been quite transformational in terms of our length of stay in those units is 9 days. Maximum. We focus the no criteria to reside or delay discharges have dropped because we've been working hand in hand with our local authorities. So the aim isn't the aim is to get Patricia home on the lowest care possible. So whereas I might have come into the wards with the Acute Trust thinking I was a pathway 3 needing to go into a nursing or residential home, or a pathway 2 that needed to have expensive care packages, actually we've reduced the number of patients who've been seen as pathway 2 by 50% to pathway 1 or pathway 0. That's a huge benefit to the local authority, who then don't have to spend money on domiciliary care or other. So there's a benefit here to the local authority in terms of different spend. There's a benefit to the individual in terms of getting them home and getting them home as independent as we possibly can. And there's a benefit to the acute trust because we're taking the patients off them as early as possible to rehabilitate that patient and get them out, which helps with patient flow in a different way. So it's still early days, but the results of us going in with a different lens around rehabilitation has already in 16 weeks demonstrated some very interesting results.
And the chief executive of the trust, I mean, that's a very forward-thinking chief executive who said, let's give this a go, actually.
Yeah, absolutely, because it's not territorial. It's not about her organisation or mine or who owns the activity. You know, Louise is absolutely of the view that she needs to empty her hospital because her focus is I've got to be able to provide really good acute care for the people who need it at the front door, and I can't do that if the back end of my hospital that isn't set up to provide rehabilitation, we're not the experts, she will say, on that, you are. Therefore, if we've got somebody else at the back end of our hospital that's doing that for us, that makes better sense because it allows us to do our job, which is be a better and more effective acute provider of care. So it is working in partnership.
And is the wards are staffed by community staff?
They are, yes.
And of course, there's a wonderful learning opportunity. I mean, as a former community nurse myself, I, always used to be upset that, people who work in acute hospitals, medical and nursing, and actually the other allied health professionals don't always understand the community perspective on things. So this is a great opportunity for the staff in the acute trusts just to see what you're doing, actually.
Completely. So an example of that is the ward staff saying, "Oh, you've got different visiting hours to us." Yeah, we don't have visiting hours. Carers can come in as part of the rehabilitative process throughout the day. Patients who come to us, we ask their relatives to bring in their normal clothes. So you wear your pajamas at night when you go to bed, not for the rest of the day. It's, kind of a very different mentality to, yes, you may still be in the subacute phase of your illness, but this is about getting you back to sort of normality. You can deal with the acute thing, but this is about you becoming that bridge back to getting back to a normality. You don't sit at home in your pajamas. Well, you might, but unless you do that normally at home, this is about getting you back to that normal way of behaving and living your life.
And of course, it enables people to keep their dignity. As somebody once said, when you go into an acute hospital, you hang your dignity up on the way in and you pick it up on the way out. And yeah. As you say, people wearing their own, these are small but very significant things on the rate at which people get better, actually.
Completely. And having their loved ones and relatives coming in is twofold. It's allowing those relatives also to be part of the care process. So the other kind of key thing is not just wearing your own clothes and having your own things there, but you're in charge of your care. You're part of that rehabilitative process, that joint contract of how do we help you and support you get back to normality and independence, and having the carers coming in and their loved ones. These might be people who are going to support those people at home. The training of how you lift somebody, support somebody, promote exercises and rehabilitation when that person goes home is a very different mentality than just, and I think much better for the relatives who then often when you're discharged from hospital, you're told that my mother-in-law's been recently in hospital. So we got the call then to say, oh, well, Zena's going home tomorrow. Right, okay. So has Zena got everything that she needs to be supported at home? Whereas the relatives can see that happening. They know they're part of that discussion process around what does Patricia need, what does Zena need to continue to support her at home. The care process doesn't just end at the point of discharge. We're there to continue to support that transition back into the community as well. So that's a big mind shift for patients too, understanding that they're part and parcel of this rehabilitative process, not something that's being done to them, it's something that's being done with them.
No, and I think that's I mean, this is proper holistic care, isn't it? But it's also an opportunity to dispel any fears that the patient or their family and their loved ones have, because sometimes it's fear that makes people want to go into hospital. You know, as you say, you're worried about your mother. Once they're in hospital, you feel safe, but there's this very sharp dividing line. And as you say, then one day you get a call to say they've been discharged. But this means that it's a very much more gradual process, with everybody gaining knowledge and confidence to be able to carry on at home.
Yeah, absolutely. And I think one example was a lady that came to us fairly early in the day. She was 104. She hadn't been admitted to hospital before, minimal input with health. She'd been a dancer all her life, and she suddenly turned around at home, fell over and fractured neck of femur. Everybody kind of thought, well, that's it, 104, she's going to end up going into a home, surely. And she was one of the first people coming out into the rehabilitation ward. And the physio said, so we're going to get you back home. And she kind of looked at us as much to say, well, that's not going to be possible, is it? Luckily, she had a very good daughter as well that was absolutely up for getting mum home. And we got her home. We got her home.
Which is fantastic. I mean, that says it all. It's not about age, it's about frailty, it's about enabling, not disabling people, isn't it? You're doing a fantastic job, Patricia. It would be lovely if lots of other people can hear this, because this is the art of the possible, isn't it? And I'm sure you are keeping figures to reinforce the case as to why this works, because everybody wants to look at the figures and, you know, how many bed days are you actually saving? But at the centre of all this is what's best for the patient.
And completely, and we are keeping the figures, which is often difficult, because whilst we can demonstrate that we've saved 90, the equivalent of 90 beds, you know, there's a whole lot of activity that comes up beyond that, and so some of it is also demonstrating with regulators and others, when we're in this kind of climate, that sometimes you've got to hold your nerve and keep the faith, because you've got to allow these kind of services a different change in culture, the way that you do things, to embed over time in order to reap those benefits, both for the individual as well as for the wider services. And I think sometimes that is difficult in this climate in particular, where we want and need to see more instant results quickly in terms of productivity and efficiency, but changing that cultural way that we've done things, particularly within the NHS, which has been very much bed-based for years, consultant-led, and that takes time to change, and also people's attitudes and the public's attitudes towards that different approach as well. So yes, sometimes we've also got to be brave and hold our nerve in some of these programs and projects. This has only been going for 16 weeks. We've demonstrated some really good results, but also in the context of, we still have a very challenged acute trust that's seeing record numbers of ambulances turning up, and we still have huge pressures around non-elective services. And so kind of trying to say to regulators, we've got to hold our nerve here, when they want to see a return on investment much quicker. And I understand that. But these processes of cultural change, both with health professionals that have to work differently, as well as the general public need to understand that rehabilitation process and react differently, takes time.
Well, I hope we've reached the moment where we will hold our nerve for long enough to see some of these things become embedded, because we've all, you know, I was a community nurse. I've worked in the NHS for 25 years myself. And I think the trouble is that good ideas like this come, usually they go. And let's hope this is one that's here to stay. Patricia, thank you very much.
You're welcome. Thank you.